And we're going to continue on the thread of extended care of the critical patient in the emergency department. Dr. Wortman got us off on a nice segue with that just really incredible case that he shared with us. Our next speaker, I'm always relieved to see, because he won't remember this, but in 2012, which my first shift as an attending, we overlapped. So Dr. Raghu Sithala always, it just kind of elicits this calm when I see you show up. So very nice to see you. Thank you for joining us today. Quick introduction for Dr. Sithala. Dr. Raghu Sithala is an emergency physician and intensivist who currently practices at Brigham and Women's Hospital and is faculty at Harvard Medical School. Dr. Sithala completed a 6-year accelerated BSMD program from Penn State University and Jefferson Medical College. After graduating cum laude from Jefferson Medical College, he entered an emergency medicine residency at Mount Sinai Center in New York City. During his residency, Dr. Sithala developed an interest in resuscitation and critical care. This compelled him to further training by completing a fellowship in resuscitation science at the University of Pennsylvania. He then went on to complete a fellowship in anesthesia critical care and critical care medicine at Brigham and Women's Hospital and Harvard Medical School, where he subsequently stayed on as faculty. As junior faculty, he learned research methodology by completing a Master's of Science in Epidemiology at the Harvard School of Public Health. Dr. Sithala has multiple leadership positions within the hospital, including chair of Emergency Response Committee and medical director of the ECMO service and medical director of the Thoracic Surgical Intensive Care Unit. He additionally is committed to education of the next generation of medical trainees, and he served as the director of the Emergency Medicine Critical Care Fellowship at Brigham and Women's Hospital and Harvard Medical School. Dr. Sithala, great to see you as always. Thank you for joining the Native American and Rural Emergency Medicine Conference this year.
Thank you. It's my pleasure to be here. All right. So let me just share my screen. And Sean, I have no idea about that. I don't remember that first shift, but equally,
I take that as a compliment. That's what you want to hear about your first shift as an attending. No one remembers it. So thanks for that.
Yeah, but I was always relieved when I saw you next to me as well. All right. Okay, so we're going to be talking, thank you for that introduction. Just some background. I am an emergency physician, but I've transitioned to mostly doing critical care. And really what prompted that was the start of the COVID pandemic. So as many places, early on, last year in March and April, the hospitals became overwhelmed with multiple critically ill patients. And, the emergency physicians really stepped up and in all aspects in the emergency department. And the few of us that were ICU trained essentially spent the, March, April, just working in the COVID ICU. So after that, I think I just continued to, stay on and practice critical care medicine. I still do emergency shifts as well, but I have an extended experience taking care of these critically ill patients with COVID-19. No disclosures. And the goals are really just to talk about, caring for the really sick COVID patient that shows up wherever you are, whether it's on the floor, in the ED, in an urgent care, or whatever setting you may see some of these patients. So the first, thing to really understand about COVID, which most of us already understand, the general public understands, is that, this is a big problem. So this is off the WHO dashboard, and, this is from a couple of days ago. So we're looking at over 160 million cases of COVID with over 3 million deaths to date. And it's a very, peculiar disease in that some people just get very, very sick that really have no risk factors. There are a lot of patients that got sick and eventually died, had multiple comorbidities. They were, diabetic, they were old, they had uncontrolled chronic medical conditions. But there was, a sizable portion of generally healthy, 20 to 50-year-olds that got really sick from this. And when that started happening last March and April, I think we were all looking at this disease and trying to figure out, well, how can we best care for these patients? This is a new disease, and they are getting very, very, very sick. So the first thing is, why do these patients get very sick? And the predominant reason is they have severe respiratory failure. They have COVID ARDS. They're hypoxemic, they have bilateral chest infiltrates, and they're having difficulty oxygenating. So, because this was a new disease and we had not seen this before, I think during the first couple of months of the pandemic, everybody was racing to figure out a novel and new way to care for critically ill patients with hypoxemia and diffuse bilateral infiltrates. And it led to a lot of different practices. I remember in March of 2020, we were intubating patients as soon as they were on 6 liters of nasal cannula, and that was very regional. And we had the resources to occupy a bunch of ventilators. But the thought process was, these patients are going to get really sick, they're going to die. And then the other aspect is they crash very suddenly. So we wanted to intubate them early to protect us. This was a new disease. There was a lot of hysteria surrounding it, and we had a shortage of PPE. So in order to protect ourselves, we were doing things to these patients that we would not have done had it been any other patient with the same set of vital signs, same X-ray, same everything a month ago, and had RSV or had influenza or had staph pneumonia. And I think that, with the rampant amount of cases going on and really hospitals getting overwhelmed with this new disease that we were not able to effectively study yet, because we didn't have the data, didn't have the infrastructure, didn't have the time or resources, because we were too busy taking care of patients rather than discovering and doing research. It led to a lot of social media, tweets, podcasts, and that's how we were learning about these patients and what the best treatment for them was before data really emerged regarding this. So that's kind of the background of how we thought about this disease as a different process than typical hypoxemic respiratory failure, ARDS, which led us to do things, and also lack of PPE and fear of contracting this, highly contagious disease led us to do and treat these patients a little bit differently than we, would for standard ARDS patients. A year passed by, and we have a lot of time to think about these patients. We can actually look at some of the literature regarding these patients. And the question is, that has come up in the critical care world and in the emergency medicine world is, really, are these patients different than standard conventional ARDS that we've had a great time? Oh, excuse me.
Her pressure is like 40.
Oh,
it's not coming up.
You need to go in that beat. Okay.
Yeah.
All right. Sorry. Apologize for that. I'm actually on service. And I really apologize. I might have to actually head out, but I will. Sean, I'm really sorry, and to the faculty.
No problem at all. If you need to step away, that's absolutely fine.
Okay.
So yeah, pressure of 40 takes precedence, I think.
Yep.
Yeah. I will be right back. I'm so sorry. I have a 30-minute presentation and time for comments. I really apologize.
No problem at all. Take as long as you need. We'll take it from here. We'll keep an eye out for you.
Okay.
All right. So we definitely have a very reasonable pause in this presentation. Ken, we're prepared for this, and I know Ken's probably got some good questions for which to help dole out some special gifts to our audience members. But I don't want to put you on the spot if you don't have anything, because I can come up with something.
Oh, no, we always riff and we can always figure it out. One question that I was going to have, or just thoughts starting from his presentation. I think a lot of us were thinking the same thing. We were following along with what readily available information we had. I was basically following the BWH COVID protocols, and looking at the WHO protocols, looking at the ACEP clinical tools for COVID. Those were sort of my primary resources. And I felt like I followed the same trend of when we started seeing it pick up in February, March, and April. Oh, that's my son banging at the door now. Hopefully he has a better blood pressure than 40 over PALP. But I felt that I was doing that same trend. I was like, okay, we're getting ready to intubate everybody. And I'm looking at a double setup for intubation and ventilation. And we're looking at like intubation hoods and the intubation tarps. I'd just like be curious, is that what other people were following? Is that what other people were seeing? Were there any other resources that you guys were using out there?
Yeah, I'll jump in as well, Ken. And so to our attendees, we're going to rely a little more than usual on cultivating that environment of exchange. So please share questions or comments that you have in the chat, or share from your own experience. We know that everybody here is taking care of a
I'm
COVID
back.
patient. You're back. Okay.
Yeah, sorry about that. I really apologize. I tried to get somebody to cover me, but
we stand ready to step in anytime. No problem at all.
yeah. So enough of my banter about what we were doing early on. But I think the crux of the situation is, after a year of caring for these patients, what I think by and large the community has come back to is we just need to care for these patients with good general critical care, emergency medicine care that we know how to do all along, and really keep ourselves safe, have the appropriate PPE, and take care of these patients and keep them safe with the appropriate PPE, et cetera. So I think there's been a big shift into kind of going back to the bread and butter basics of how to care for these patients, with a couple of nuanced differences. And that's what we're going to focus on over here. All right. So the first thing is, when you have some of these critically ill COVID patients, what is the main problem? Why do they present to your emergency department, your urgent care, your ICU? It's because they have hypoxemic respiratory failure. So over 90% of ICU admitted COVID patients are ventilated, with 10% requiring some sort of standard, escalated oxygen. And then only about 15% actually have cardiogenic or hypotension or other issues. And about 15% of them, of those other patients, also develop acute kidney injury or renal failure. And what we start with is having a protocolized oxygen escalation pathway for these patients, because they do differ from our standard regular, influenza / MRSA pneumonia patients, in that when they start getting worse, they all kind of follow a very similar trajectory, and we need to be on top of them. So what we do here at Brigham and Women's Hospital, which, and there's many other protocols that are out there looking at these, is start with a stepwise escalation of oxygen therapy. So patient comes in and they're satting under 92%, put them on nasal cannula and increase their nasal cannula. For a normal patient, you really want them to sat, above 92%. For somebody that's got chronic pulmonary disease, COPD, we'll tolerate our typical lower sats in those patients. And this is where the protocol can vary depending on the resources you have and what institution you're at. But once you get over 6 liters of nasal cannula, there's really no point in increasing the nasal cannula. What happens is, when your flow gets higher, you're actually not seeing that, because it's a nasal cannula. and you're actually entraining tons of room air in with you. So you can go up to, 10 liters for your standard nasal cannula, and you're not really going to see that effect from above 6. Now, that's different when you get to really, really high flows, and we'll get to that further down this algorithm. So once you get over 6 liters, you have to see what's the next oxygen therapy, oxygen device that you have available at your institution. So here we escalate to something called an oximizer, which is a nasal cannula that has a reservoir. So you're able to get a higher amount of oxygen because you have this reservoir, or a Venturi mask, which you can titrate your FiO2 based on that. But once you get above that and your SATs aren't improving, then escalate rapidly up to a non-rebreather mask. So for places that don't have the oximizer or the Venturi mask, you can just escalate up to an oxygen mask and the non-rebreather mask. And this is where what we've changed over the past, I think, year taking care of these patients is we started introducing non-invasive ventilation more. So the first studies and reports of high flow nasal cannula and using non-invasive ventilation, I think, came out more of a necessity than actual thinking that this would help. It's because places ran out of ventilators, so they had to look at, well, we don't have enough ventilators. How are we going to provide these patients with more oxygen and more support? So we started getting experience with using non-invasive ventilation, high flow nasal cannula prior to intubating these patients. Our general preference here is to go from a non-rebreather mask to a high flow nasal cannula, and then really not use BiPAP and CPAP unless they have a condition that generally required BiPAP or CPAP, or that we know that there is good evidence and supports. For example, they have a COPD exacerbation and have COVID, not necessarily they have full-blown COVID ARDS and have a history of COPD. In that scenario, we would escalate down a high-flow nasal cannula pathway and then intubation. And we'll go over some of these benefits of why a high flow nasal cannula. So a high flow nasal cannula, they have several commercial devices. And the big thing about these nasal cannulas is you flow 40 to 60 liters. So with that much flow, you don't entrain room air. It matches your respiratory inherent flow rates, and you're able to actually give 100% FiO2 via high flow nasal cannula. While with the non-rebreather, even though it's 100% and you're blasting 15 liters, you really don't get more than 70% inspired oxygen when you're on a non-rebreather. So the high flow nasal cannula gives you more oxygen. It's more comfortable because it matches your flow. It's heated and humidified. And with that high flow, if you are closed mouth breathing, you actually get about 5 centimeters of PEEP with that. And furthermore, there have been a couple of non-COVID hypoxemic respiratory failure ARDS studies showing that with high flow nasal cannula, you had mortality benefits over BiPAP. So in general, if it's available, it's a great tool to use. And then that's the Florali study, which was the big study that demonstrated the benefit of high flow nasal cannula. So here is a COVID-related study regarding the use of high flow in South Africa. And I thought this was a very interesting study because it was in a resource-constrained setting. And what they found is that these are all patients that had very, very low oxygen saturations. And they either got high flow or as opposed to getting intubated right off the bat. And they found that about half of the patients that otherwise, met, a standard criteria to be intubated were able to be managed on high flow alone without getting intubated, while half of them, ended up getting intubated. But that's still a great, save to not have to use a mechanical ventilator and able to really be managed and not have all the downstream effects and consequences of being on the vent, which we know is not, great. You can get a ventilator-associated pneumonia, you get weakness, you have to be on tons of sedation to tolerate the ventilator. So this was a nice study showing that even in a resource limited setting, they were able to manage these patients with just high flow nasal cannula and save X number of ventilators. So when we put somebody in high flow, I like to, several ways. You can start a little bit lower and go higher, or you can just start at the max and titrate down. I generally tend, especially in the emergency setting, I tend to start everything high and then bring it down. So initial settings, 60 liters of flow, 100% FiO2, and then watching their pulse ox and titrating down. And that's how I use high flow for really most hypoxemic respiratory failure that doesn't need to be intubated emergently. And we know the patients that need to be intubated emergently. You look at them and they look like crap. They're breathing in the 50s. They're hypotensive. They're completely altered. They're not protecting their airway. So that's not the patient we're talking about. We're talking about the patient that's awake, alert, relatively tachypnic, and just really not saturating well. And that's the patient that high flow, I think, has the best benefit in before going straight to intubation. And in COVID, with non-invasive ventilation, BiPAP, CPAP, just for hypoxemia, I think we can avoid those patients and just do high flow for them. So the other important thing is, as you saw in that South African study, about half the patients that go on high flow end up failing. So you really have to be able to monitor these patients and look at them and know, are they at risk of failure? And if they're going down that trajectory, it's always better to intubate them early rather than wait until they're fully obtunded. And now you can't pre-oxygenate them. So you have to go intubate a patient setting 60% despite maximal oxygen therapy. And this was a nice multi-center observational study that looked at, what are the things that could potentially predict high flow nasal cannula failure in COVID patients. And what came up was something called the ROX index. And this is something that had been studied actually in non-COVID patients. And it's really, a simple tool. It takes just one ratio and they do it at 2 hours, 6 hours, 12 hours. And what you do is you take what their pulse ox is and divide it by the inspired FiO2 in decimal point. And then you divide it by what the patient's respiratory rate is. So having a low number is going to predict failure. And these are the numbers that were studied. So I don't recommend ever sitting at the bedside and calculating, these indices, but it gives us an idea of what are the things that we really need to watch out for. And it looks like respiratory rate is going to be the big thing that drives our ROX index really low. So, and looking at their trajectory. So if after 12 hours of high flow nasal cannula, you find that the patient's the same, okay, maybe you can continue it, but you find that they're gradually getting worse, it's highly unlikely that they're going to get better if after 12 hours, they've been gradually getting worse. And that's the patient that I may prophylactically intubate. Because the other thing that we don't talk about is when you are spontaneously breathing and you're breathing crazy, like, even though you're not on a ventilator, breathing like that is injurious to your lungs. So you could be promoting lung injury by generating these big pressure swings. So what I tend to do is I look at the patient. If they're able to speak to me, they're calm, they're a little tachypnic, but they're not working hard to breathe, I will tolerate lower O2 saturations and ride them out on high flow. And I'll do another therapy that we will talk about in a sec. But even if their SAT's 92%, but they're breathing at 50 and they're working hard to breathe, that patient needs to be intubated because they're not going to get better. COVID takes a long time when you're that sick to actually get better. It's not like you're better in 5 days. And then moving to the next thing I was going to talk about is what we found is COVID patients improve their oxygen saturations when they are prone. So if a patient is able to, and they're awake and alert, and they're, able to turn on themselves and turn over, I highly recommend awake proning. There are pros and cons. So why is prone position, even a good idea? Why is it helpful? What it does is it increases your ventilation and perfusion matching, and it also increases recruitment of the lungs. So if you look over here, so this is a non-COVID study. This is one of the original older CT studies demonstrating why proning is beneficial. So at the top, you have a patient that's supine, and you can see that the posterior basilar segments of the lung are completely atelectatic, and the heart is very big, and it's exerting, kind of compression effects on the posterior lung bases. And we have actually more volume in the posterior bases of our lung. So now you turn the patient prone, and look what happens. You get the weight of the heart off the chest. I'm sorry, the weight of the heart off the posterior lungs, and the posterior lungs that were fully collapsed before are now able to aerate. And that is a larger surface area that's allowed to participate in ventilation and perfusion. The other thing is the blood flow actually changes when you go supine to prone, and that blood flow matches more where the ventilation is. So that's another reason why proning is helpful. So early on in the pandemic, a lot of centers had experience with awake proning. And here's one of the first reports in the emergency medicine literature. This was done when a friend of mine, Ruben Strayer, over in New York, and Rich Levitan, a famous airway emergency expert. And this was what they did for their all comers that were hypoxemic, and they reported their experience. So the median pulse ox was 80%. They applied oxygen. They were able to get the patient up to 84%. Then they proned him. And then really just after 5 minutes of proning, they were able to see a 10-point increase in their oxygen saturation. So I highly recommend awake proning if the patient is able to. If the patient's not able to, and you really have to do all the work for them, you may run into more trouble than not. And the other aspect is anytime we do something like proning, where tubes and lines and drains are at risk for getting dislodged and things like that, it's really important that you have a protocol. Whatever your institution you're at, you should have a protocol that everybody's familiar with, the respiratory therapists, the nurses, the docs, the PAs, whoever else may be participating in this, just so that we are all, aware of the risks of proning and the benefits, because there are risks, and the big ones are if they get worse all of a sudden, you're going to have to flip them over. You don't have access to the airway. You could dislodge important tubes and lines, like the IV access, et cetera, central lines. So it's a good idea to prone, but it definitely always weigh the risk and benefit. And the other thing is, for awake proning, we really don't have mortality data to demonstrate that this saves lives or prevents intubation. What we do know is it improves oxygen saturation, and it's real time. You'll see it right in front of you. So I talked a little bit about BiPAP. So I generally tend to avoid BiPAP in these patients, mostly because of the BiPAP is probably the mode of oxygen delivery device that has the highest aerosolization. And also, it's not entirely clear that there's a huge benefit of BiPAP over high flow nasal cannula for just pure hypoxemic respiratory failure. But if you are going to use BiPAP because that's all you have, I think it's reasonable to use it. Just got to make sure that you're doing it safely. So if you have a negative pressure room, airborne precautions, and then ultimately make sure that there's a viral filter on the expiratory limb to really decrease that aerosolization risk. So now the big question is, when should I intubate? And it's early on during the pandemic. There were centers intubating early. There were centers that were saying, no, don't intubate, because once you intubate a COVID patient, they're all going to die. And ultimately, I think it's you intubate the patient as you would any other patient. We know if the patient is obtunded, not protecting their airway, they're in multi-pressor shock, we should probably just take control of the airway. But for the patients that just have pure hypoxemia, I would ride them out. If they're comfortable, they're able to speak to you, I would ride them out and see how they do on high flow nasal cannula with self-proning. And if they're, the markers that we talked about, if you're going to use the ROX index, if you're going to just look at the patient and they're getting more tachypnic, working hard to breathe, those are the patients that I would intubate. Otherwise, it's just bread and butter emergency resuscitation. The patients that you're going to intubate are the patients that you're going to intubate. And I think there's another presentation regarding intubation of COVID-19 patients. So what I would say is that minimize aerosolization of the virus is a key factor. Maximize first attempt. So I highly recommend video laryngoscopy for all of these if available, and then have as the least number of people in the room that you need, so you can reduce exposure. But otherwise, it's going to be standard RSI with video laryngoscopy and the most experienced person to make sure you just get the tube in ASAP. Because the other aspect is they do precipitously desaturate. So you really want to maximize that first pass attempt. All right, so once you get the tube in, how do we treat these patients? And again, what we do is we treat them like all of our standard conventional ARDS patients. So these are the only things that have been shown to improve mortality. There's all this other things out there that may help improve oxygenation, but low tidal volume mechanical ventilation and prone ventilation are the only two things to date in a randomized control trial fashion that have been shown to improve mortality for patients with acute respiratory distress syndrome. And then some newer data is hinting that there is probably a population of ARDS. Their mortality will benefit from being on ECMO rather than continuing with conventional ventilation. So we got the patient tube, they're in our emergency department, they're in our resuscitation bay. What should we do? So I recommend just following standard ARDSNet protocol, which is assist, the mode of ventilation is assist control, volume control. The tidal volume we're going to set is 6 cc's per kilogram of predicted body weight. And the predicted body weight is based on their height. I can never remember what the formula is, but you just, if you look it up online, the ARDSNet, they actually have a table, and you can easily, you see how tall, if they're male or female, how tall they are, and they tell you what the tidal volume should be. And I start with a generally higher respiratory rate, usually around 24, just to start with, because they're usually at that point, they have high minute ventilation. They've been tachypnic the whole time. So I want to be able to match that and make sure I don't drop their pH by not matching their respiratory rate. And the other thing is when they were spontaneously breathing, they were probably taking big tidal volumes. And now when I put them on the ventilator, I'm giving them kind of tiny tidal volumes. So I'm going to have to definitely compensate with a higher rate. And then empirically start them on some PEEP. By the time a COVID patient needs to be intubated, they usually have some atelectasis and some derecruitment, so they will need some PEEP. The higher BMI patients, I put them on higher PEEP. So that's just to start out. I got the tube in, and these are my initial vent settings. Then I start making ventilator adjustments, and these ventilator adjustments are, like I said, I start high and bring them low, as opposed to starting low and increasing the vent adjustment. So I just start titrating the FiO2 to the lowest possible to make them sat, anywhere from 92 to 96%. And if you have access to getting a blood gas, an arterial blood gas could be helpful. But at the bare minimum, you should check a VBG just to make sure that your respiratory rate is high enough, because a lot of them need a very high respiratory rate. Otherwise, they'll be very acidotic. So I'll check a VBG and just make sure that my pH is okay. And I'll start increasing the respiratory rate if the pH is too low. So now what do I do if I've done that? I've intubated the patient, I've done my initial vent management, and they are still not doing well. And this is, this was an all too common scenario that, when as emergency departments were getting overwhelmed with these critically ill COVID patients, we saw this. And what we developed, and I think it's really important, is a lot of centers is just develop a stepwise, just like we had the stepwise escalation pathway for before they were intubated. You should develop something that fits your institution regarding its resources on what you can do in the emergency department or the resuscitation bay or wherever you are that can, sorry, 1 second. Again? Okay. Sorry, I will be back again. I really apologize.
Perfectly fine. Perfectly fine. We were saying he's getting street cred, getting called away. Dr. Sathala, this is fantastic early on in the discussion. A couple of things I wanted to point out is I absolutely experienced the real-time effect with proning with some of our patients. We had a couple of very good questions regarding the high flow nasal cannula. From Artemis, is there any study with high flow nasal cannula that used the prone positioning? I have to tell you, I don't know if that's the case, but we'll make sure to follow up with Dr. Sitala. And then Elizabeth Sansu, that's coming from, I believe, Bethel in Alaska, was talking about actually having the staff and the protocols and policies in place to use high flow nasal cannula. I made a flippant comment earlier talking about did people put money in the budgets for these actual machines? But more than that, if you have respiratory, are they on board with this, or will nursing be on board with this? This has been a challenge at a couple of our sites, even that have high flow nasal cannula, to be able to put it on patients. And then furthermore, where do these patients go? Are they staying in the ED, or will they go to an ICU, or where else they go? So please, if folks have those protocols, if folks have, or if we in our collective IHS group have a respiratory therapy team or clinical consultant that could help us disseminate some of these trainings, or nursing colleagues and nursing leadership in particular have this experience, I think we would all benefit from that training and education. Another question is, do we have inhaled epoprostenol or NO? I do not believe that I have worked at a site that'll have that available, but there was a recent MRAP, that is emergency medicine RAP. I can't remember what it's for, but it's an excellent podcast that we use, and you can actually use inhaled nitroglycerin, and that's another one that's coming up as well. Somebody already put that on. So we all have nitro, and indeed we can try inhaled nitroglycerin for some of these patients. And I don't have the protocol, nor have I ever set that up. So I would have to refer to my pharmacy colleagues as well as EMRAP. Sean, anything to add?
Sean, I think your audio is muted for some reason.
I think I got a failure of the earbuds, so I'll talk to
Nope, looks good.
talk to Tim Cook about that. So Kate Elkins, thank you from NHTSA. Thanks for your comment. This is a really important one, I think, making sure your teams have the right equipment to bridge folks during transport. So this is something that I've experienced in Fort Defiance. I'm sure other folks have. It's probably not going to do a high flow nasal cannula patient much good to de-escalate to a non-rebreather for transport. So I think that's and happy to field any comments or questions about that. I think that's a pretty important consideration if you're looking at a long distance 1, 2, 3 hour transport, and that patient needs to keep that respiratory support in place. I don't think you want to de-escalate that at all. And that's something that's been very real in the setting I work, and I'm sure other folks in this area. Great point, Kate. And also wanted to draw attention to what Dr. Sitala pointed out about the role of BiPAP or CPAP, and it's much more targeted than what I remember from a year ago or even 6 or 8 months ago, where the recommendation is currently to use BiPAP in those patients who have another clear indication and proven mortality benefit for BiPAP, such as COPD. So I think that many facilities, many departments, many providers have used BiPAP as a part of the rotation of respiratory support options during COVID. But it seems pretty clear based on Dr. Sitala's presentation that the role of BiPAP should be limited to, or targeted rather, to folks who have a very clear pre-COVID indication for the use of BiPAP.
Do you mind if I jump in, Sean?
Please, that'd be great.
So just to kind of go along with what Regu was saying, we went for, I would say, about a year, like really not using BiPAP on anyone. It really scared everyone to be using it. And then slowly over the past, let's say 6 months or so, we've been starting to use it, like you said, for really the people that we think are kind of asthma, COPD, congestive heart failure. But you also just brought up, we had some real issues working with our local EMS agencies at the community hospital I work at then. having someone that we put on BiPAP, they really didn't feel comfortable putting them in the back of an ambulance in an enclosed space with BiPAP or CPAP on. So really judging, is a transfer, kind of knowing your distance to your receiving institutions, is that going to be safe? Versus kind of what are the protocols. A couple other quick points just about this slide that Raghu has up. We have some pharmacy colleagues and toxicology colleagues who've really looked at the sedation needs, and the sedation needs, for reasons that I can't fully explain, are just huge. So they really have been teaching us to use large doses of sedatives, not only for kind of post-intubation sedation, but also for induction and intubation. So in addition to the normal medications, like also recommending about 5 milligrams of Versed, because sometimes it takes a little while for the other stuff to get on board. And then really that paralysis is going to be important. And then we have the ability to do inhaled EPO or nitric oxide at our institution. We don't do it all that often until they get up to the ICU, but some of the critical care transport agencies do. So another thing just to kind of know what the resources are locally.
And so with regard to those agents, Andrew, do you all have a protocol in place, or is it at this point still in the stage of kind of critical care attending discretion?
So in the emergency department, we can start them. It's usually us working with respiratory therapists. I don't frankly think it's that complicated. Like it's not careful titrations. It's a lot more difficult to start intravenous epoprostenol, which we don't do in the emergency department, but if we wanted to, we can start inhaled, and it's not really that challenging, actually.
Interesting. I think so. That's something we should all be staying tuned for as the standards around the use of those agents emerges. Josh had a comment. Josh, I'm not sure where you're practicing, but interesting to hear that you were given these ventilation helmets out of University of Chicago, and be curious to hear if anybody can drop in the chat if they have experience with that. I have not seen those. Andrew or Ken, either of you worked with the ventilation helmets?
I saw a couple of transports out by Guardian Air, which is one of our transport companies that we work with on the res, but I have not set them up personally, nor have I used them. No.
And I believe what we're talking about is kind of a whole kind of hood that you put on. It almost looks like kind of like a astronaut space helmet, and it's designed for people for whatever reason who can't really tolerate. My understanding is for people who can't tolerate normal face masks for BiPAP or CPAP. It kind of creates that same positive pressure just around the entire head. I have not used them, but it's an option, but I don't think we stock them.
And that's interesting. I haven't had the chance to use those yet. Kate Elkins dropped a couple of points that are, I think, really important when we consider the transport of these patients, and which opens up, I think, another line of conversation. And that's that, EMS crews don't have good airflow. They're in a very tight space, often, especially if we're talking rotor or helicopter transport. So we need to make sure they have the right gear before you transport a patient. And then, of course, the airway management. This is something a little different than what we would see in an urban center where we're talking about, again, 1, 2, or 3 hour transports. And we're making airway and ventilatory status decisions based on predicted clinical course, which should always be a part of our intubation decisions. But this is one that's in the next 3 hours. What do you think is going on with the patient? I'm certain that those folks on the line who practice in these remote locations use that as a part of their decision making. But it's hard, as I understand it, it's hard to intubate. It's not easy to intubate in most helicopters. And so you want to really set the patient and the crews up for success in transport, which probably means pulling the trigger for things like intubation and non-invasive positive pressure ventilation earlier than we otherwise might.
These are great comments. Thanks, everyone, and thanks for bringing in that EMS and that medical transport perspective in there, Kate. Dr. Norquist, who's going to be discussing a lot of our airway management, the changes in COVID, had put a comment in that the limitation of the hoods is going to be the high flow rates that are necessary. and especially when there's some oxygen constraints that have been going around internationally, as you guys may have heard in the news. I bet that would be soon become an issue for us here with regards to the supply of medical gas. It's 9:45. We're going to transition to our next talk anyway. Thank you so much, Dr. Sithala. We'll get back with him, and you guys will share these slides, and we'll try to get more information from him as he comes back. But he's a busy clinician on shift currently, and we have to thank him so much for even trying to take the time to be with us. So thank you.
And Ken and Sean, just on his behalf, I'll apologize. He told me just before he came on that he just emergently put someone on ECMO, which is one of his roles. And I think it sounds like they're having some complications. So apologies that he didn't get through all of his content, but we can make the slides available to folks if that would be of interest. And he's a wonderful guy and a great colleague of mine and Sean and Ken's. So we're thrilled that he was able to make the time, but we will get the slides out to folks if they're interested.
Thanks so much for that, Andrew. And yeah, that's about, there's probably maybe literally no better clinical reason to step away than putting somebody emergently on ECMO. So thanks again, Dr. Sithala, for your time. And we look forward to doing this again with you.